So here we have a 60-year-old male complaining of fluctuating vision. Now, as you can see, there's a nasally dislocated rigid monofocal IOL. Explantation of this lens would require a large scleral incision. Should we save the IOL bag complex instead? Okay, let's try this. So here, a side port incision was created at approximately 3 o'clock position, and intracameral lidocaine and epinephrine were injected. The pupil remained around 5 mm dilated. A viscoelastic gel was injected into the anterior chamber to tamponade the vitreous and push it posteriorly. A capsular hook was then inserted through the previously created side port. However, the capsular bag was too posteriorly dislocated to allow direct engagement. Now, at this point, the bag was levitated using a second instrument. A 30-gauge needle was introduced around 3 mm from the limbus, bevel up, taking care not to puncture the capsular bag. The needle was advanced slowly to gently elevate the IOL capsular bag complex. Once adequately positioned, the capsular hook was secured, and I instructed my assist to slowly lock the stopper in place. Now, an extra hand really comes in handy. After achieving a stable fixation of the bag, the needle was carefully withdrawn. A main incision was created using a 2.4 mm keratome. Additional visco-dispersive gel was injected into both the anterior chamber and the capsular bag. Additional capsular hooks were placed to further stabilize the bag. In this case, a previously implanted CTR was seen to be already present, so a capsular tension segment was used to secure the nasal zonal defect. A 6-0 Prolene suture was threaded through the eyelet, and the tip was flanged to an adequate size to secure the suture and tested to prevent slippage. The main incision was then extended using the same blade to allow passage of the segment ring. During insertion, the flange got caught on the corneal incision lip, so care was taken to fully insert the flange into the anterior chamber before proceeding. Using microforceps, the trailing end of the segment was positioned securely within the capsular bag. The nasal capsular hook was subsequently removed through the main incision. 2 scleral marks were made, the first 2 mm posterior to the limbus and the second mark 2 mm from the first. Before introducing the needle, microforceps were used to assess the space between the iris and the capsular bag. Now, once the needle tip was visualized intraocularly, Prolene suture was prepared and slowly threaded through the needle. Then gentle externalization was done through the sclera. The suture tip was cut, flanged using low-temp cautery, and buried subconjunctivally within the sclera. And we're done. These are the before and after, 1 week post-op photos of the patient. Happy patient and an even happier doctor. I hope you enjoyed the case as much as I did. Here are some surgical pearls that would hopefully be useful in your future cases. Thank you for watching. Don't forget to like and subscribe.